we're going to go ahead and get started here. I just want to say thank you all so much for joining us this evening. We are really excited to be here and very, very excited to be partnering with Prevent Blindness Texas on this evening's event on our Thyroid Eye Disease Patient and Caregiver Empowerment Forum. So a brief overview of what our agenda looks like for the evening. You'll be hearing from myself, a little bit about the Vision Health Advocacy Coalition, as well as from Prevent Blindness Texas. And then you will hear from Dr. Zev Shulkin, a little bit of a Thyroid Eye Disease 101 presentation, and then from Layla Lohman on kind of patient advocacy and what it means to be a powerful patient. And as you'll see at the end here, we do have some time for audience Q&A, so if you do have questions for our patient or for our provider, please do save them until the end, and we are more than happy to answer those. A little bit of a brief introduction into the Vision Health Advocacy Coalition. So we are a coalition that works to promote patient-centered policies, really that make services, devices, and life-changing treatments more accessible for people with vision conditions. We have a fantastic set of members, as you'll see up here, really wonderful partners in the work that we do, and really could not do the work that we do without them. And a little bit of an overview of some of the work that we do here. So we have kind of 4 main areas that we do a lot of our work in. The first of that being awareness, and that's really a core value of the work that we do. We really try and raise awareness around vision conditions, really through empowering patients through both education and resources. We also work on the policy side, so supporting patient-centered policies, really ones that will impact patient access, especially for vision patients, and so utilization management and other access barriers for patients. We also work on patient education, so events like this evening's event, both virtual and in-person events for patients, for caregivers, really partnering with our members and other organizations to kind of provide educational resources, to provide information. A lot of our events can be found on our website as well, as they are often recorded. And then we do a lot of work on rare vision conditions, so educational resources and program around those efforts. So I am excited now to hand it over to our partners for this evening, which is Prevent Blindness Texas. So Michael, I will hand it over to you here.
Good evening, everybody. So Michael Vitale, I am Vice President of Membership, Government Relations and Technical Affairs for the Vision Council. I am a board of Prevent Blindness. I'm a board member. And since I live here in the Dallas area, they asked me if I would come up here and do an introduction. This is the first time I've seen this presentation, so you're gonna have to bear with me a little bit as far as, I don't necessarily like to read it, but I don't have a lot of choice here. So Prevent Blindness Texas was founded in 1956, and we are the state's leading public health nonprofit agency dedicated to sight conservation. Our mission is to prevent blindness and preserve sight. Our vision is vision. I love that because at the Vision Council, we say vision care is health care, and so I love that there. Making healthy eyes a priority in Texas. What's really nice is over the past 2 years, we've served more than 100,000 individuals statewide, providing screenings, education, navigational services, financial resources to improve access to vision care and treatment. Our goals and priorities: long-term impact goals, preservation of sight, prevention of vision loss, elevation of eye health as a critical component of the overall health conversation, PBT to be seen as the thought leader, influencer, convener, and change in the eye space, elevation of Prevent Blindness Texas as an advocate in eye and overall health. I think all of us know that there's so much that can be seen in the eye when someone's having visual problems that can definitely tell that they've got a lot other problems going on within the body. Our priorities are awareness, access, and advocacy. We have a staff of 9 across the state. We have 21 board members representing various aspects of the industry and non-industry across the state. Our core values are empowerment, accountability, and client-focused. The keys to our culture are transparency, community, collaboration/partnership, integrity, and communication. So how do we do our work? We assess the needs of our communities. Why does this keep doing this? Assess our needs of communities across the state and work with all different organizations, partners, individuals to move our mission forward. Grow investment in sustainability and eye health across communities by educating and training hundreds of volunteers. That's one of the keys that we do, is we train screeners that then can go to, whether it be a job site, whether it be a school, whatever, to do screenings that are much more than the typical screening that a child might get as they're entering in school. Work along the entire continuum of eye care to close the gaps for patients and focus on improving access to care, increase individuals' knowledge of eye health and vision issues to help people take action in their care. So what do? We screen individuals, hoping to identify potential vision problems, and then finding that early enough that we can truly help them. Train community partners and volunteers to perform certified vision screenings, education on eye health and safety topics, understand the barriers to receiving eye care through our process, and then navigate individuals at a risk of vision problem for the next steps in eye care continuum with eye care practitioners. So what are the ways to prevent vision loss? Early detection and treatment. This must be on a timer. It's trying to rush me out of here. Early detection and treatment. I can't say enough, and I know we've got a small group here, but the advocacy for comprehensive regular/annual eye exams. This is one of the things that even in my regular job that I'll say that has always frustrated me. I am a licensed optician. I don't practice optician anymore, but the fact that like a lot of the optometrists out there don't necessarily believe in a once-a-year eye exam. They say, I'll tell the patient when they need to come back. And if we could just do like the Dental Society did, which Colgate wanted to sell more toothpaste, so they convinced everybody they needed to have cleaning twice a year and x-rays once a year, and now we all do that as part of our normal thing. So if we can just do that for eye exams, we can help out a lot. Patient education, eye care resources, and definitely patient follow-up. So how can you get involved if you would like to get involved? Well, you can become there it is on a timer. If you can become a certified prevent blindness vision screener, become a referral partner agency, volunteer or attend our special events. For those of you up here in the Dallas area, we have an event every year at the Arboretum in Dallas in November, and it's a fantastic event. It's a women's event, I think is the way but it is just a fantastic event. So, I hope you go to our website, which you're gonna see a QR code in a minute, and then, and join us there. Join our board, join our committee, get involved. Become informed about our internship opportunities, sign up for our emails, follow us on social media, and then become a continuum of eye care partner. We are on the major social media channels. I was just told that we have a brand new podcast that was just released. So if you're on LinkedIn, Facebook, X, I guess it's probably across all of them, look for it, download it. I haven't seen it yet, but I will for sure. And then in closing, here's our email address. Here's a QR code you can scan. I promise it won't send you to some crazy site, but scan it. It'll take you to our website where you can learn more about us. Folks, I've been in the industry for 48 years. I know you don't think that's at all possible. Started when I was a kid in high school in the optical industry, educated myself in the industry, and then I think it's past 5 to 6 years that I've been involved with Prevent Blindness Texas, and I got involved because as you age, you say, okay, how can I give back to everything I've done? And I've done that through continuing education for spectacle fitters and contact lens fitters over the years, and now it's a case of how can I give back to society as a whole, and that's why I really love it. So we hope you'll take the opportunity to at least learn more about us, and then definitely join us when we're here in November. Okay, any questions for me regarding Prevent Blindness? No? Okay, I think we're good. And then okay, so I'm introducing Zeb. We just met, so it's all yours. Get to it.
All right. Thank you guys for having me. I want to thank Dr. Lohman for putting this together tonight. Well, it was your idea, and you are a wonderful patient advocate, and have taught me a lot about practice and about how we treat disease, and a friend now as well. So thank you for putting this together, and thank you all for being here. I want to make this as informal as possible. So if you have questions, as we go along through the slides, we'll just ask them as we go along. And so please feel free to I know we'll have questions at the end, but feel free to raise your hand. So I'm an ophthalmologist, so I do basically eye surgery all day long. And I do eye muscle surgery and eyelid surgery. So I trained as an ophthalmologist, and then I did 3 extra years of neuro-ophthalmology, oculoplastic surgery, and pediatric ophthalmology. And so the disease process that blends these 3 together is really sort of thyroid eye disease, or Graves' disease. And so it's something I'm passionate about. It's something that we learn about every day, and it's really sort of been a fascinating journey for me to treat patients with this disease and this disease process. So let me sort of go through some quick slides on what thyroid eye disease is. So thyroid eye disease is an autoimmune disease. It occurs when the immune system basically tells the eyes that something is wrong, and it starts to make fat and muscle behind the eye get bigger, essentially. That's what's happening with thyroid eye disease. Sometimes this is associated with hyperthyroid. Sometimes it can be associated with hypothyroid. And then there are some patients that have normal thyroid, but their eyes act like they have thyroid problems. So we have to think about that just because your thyroid is normal doesn't mean that you're necessarily going to have, that it's going to correlate with the eye disease. Hi, come in. Great, have a seat here. Great, welcome. So who's at risk to develop thyroid eye disease? One is patients with hyperthyroidism. My sister, before her wedding, came up to me, and her eyes looked like they were bulging out of her head, and I was a fellow at the time, and I said, there's something wrong with your thyroid. And she got mad and said, there's nothing wrong with me. And the next day, she was at the endocrinologist's office, and her thyroid was super high, and has fought this disease ever since, and that's been 15 years. So it can be chronic. So anyone with thyroid disease, whether it's hyper or hypothyroid, needs to be thought about when we see eyes that bulge or people who have double vision. It's more common in women than men for reasons that we don't really know, but we know more women develop autoimmune diseases than men. So smokers get this really bad, so we always tell our patients not to smoke. Anyone who's had radioactive iodine therapy, that's a pill that you take. If your thyroid is really high, you'll take a pill and it will destroy the thyroid gland, and then the patient will take thyroid hormone to replace it. That can make this disease worse. And then anyone who has this in their family, I have a very strong history of thyroid problems in my family. My mom has it, my grandfather had it, my wife's family has a lot of history of thyroid disease. Our baby had low thyroid when she was born. So this tends to run in families. So that's something to keep in mind. So the symptoms of thyroid eye disease, how do we tell patients that this is what they have? Their eyes can bulge. They can have pain. The most common patient that comes into my office is someone who has eye pain and dry eye. And that's how we pick up on this. They can have irritated eyes. They can have light sensitivity. They're uncomfortable. Their eyes can be red, bulgy, and their eyes can be swollen. And the other thing I would say is anyone who has eyelid asymmetry, anyone who comes in whose eyelids look different, that's the first thing I'm thinking about. That's the light bulb that goes off in my head. We know that there's sort of 2 phases of this disease. One is the active phase. Someone comes in and their eyes are really irritated, and that can last from between 6 months to 2 years. And we don't patients are not in a box. So this is not like an absolute thing, but this is sort of how the dogma has been handed down to us for 60 or 70 years. Patients have progressive inflammation, they have swelling, they have gritty eyes, they have vision, they can get vision loss. Patients can go blind. I have had more than one patient go blind from this disease, and that is an emergency, and we can reverse it, but it has to be recognized and handled in a proper way. Patients can get what we call lid retraction. One eyelid is too high, either the upper or the lower lid, and that is very common. That's the most common reason someone would show up with this disease. And then we have this inactive or this chronic phase that we're learning more and more about every day. And this occurs when the disease sort of stops, but no one really gets back to normal. And so that's the chronic phase. So patients may get double vision, they may get bulgy eyes, and this can last a while. And this is what the eye looks like. So the healthy eye, and we can see here, this is a healthy eye, right? This is the eye and the eyelid. These are the eye muscles that help the eyes move. And in a Graves' patient or a thyroid eye disease patient, the muscles get big, the fat proliferates, and the eyes bulge forward. And so that's kind of what you need to think about, is that's the eye gets boggy, it gets heavy, it gets filled with fat and water, and it sort of gets, that's what causes the bulginess. And then when you're inactive, your eye may go back to sort of this picture on the right, but there's still some fat, the muscles still may be scarred, and the patient really never really gets back all the way to normal. So let's talk about some common terms, like inflammation. We talk about what is inflammation. We hear that on TV, right? Inflammation. It means that the body is reacting to something, and that causes things to get red, to get inflamed, and to hurt. And that's what inflammation is. If you have an inflamed knee, your knee is irritated from exercise or from trauma, and white blood cells and red blood cells come in, and that causes a cascade, and that joint becomes inflamed. And that's what we take Tylenol or Advil for, to reduce inflammation. The other thing we need to talk about is eyelid retraction. And so eyelid retraction means that an eye is too high or too low, right? So this person, you can see the white of their eye on the top of right here. So this is called retraction. You can get upper and lower retraction. And that's what causes the eye to look bulgy. So eyelid retraction is really important when it comes to talking about patients with thyroid eye disease. Proptosis, that means the eye bulges forward. It can bulge forward, it can bulge down, but the eye is bulging forward from that fat. That fat pushes the eye forward. Not every patient has proptosis, but it's an important term to know about. And then diplopia is double vision, and that's a lot of what I do all day long, which is deal with patients who have really bad double vision from their thyroid eye disease. And it's correctable. It may not get perfect, but it's a correctable problem. So again, these are like the signs: dry eyes, swelling, pain, bloodshot eyes, light sensitivity, double vision, retraction, blurry vision. And this little chart on the right-hand side of the screen is something called the CAS score. Very common, it was sort of like the lingo that we use to talk about our thyroid eye disease patients when Tepezza came out, which is something we'll talk about in a second. But we would add up the score, and we would sort of tell our patients, this is your score and this is how active you are. A low score meant that you were not really that active and your disease process was pretty low, kind of like saying someone has a cholesterol of 300 or 200, right? And so 200 is a little high, 300 is like sort of off the charts. This CAS score was sort of the lingo. We've gotten away from it a little bit. It's not that hard to get to a pretty high score pretty fast if you're really listening to your patients. I would just tell you that. Like, if you really sit down and you really talk to your patients, to get to a 6 or a 7 is not hard, because some of these patients are pretty miserable. So you really got to like listen to them and think about what they're telling you, right? So if they have pain, they're a 2. And if they have eyelid swelling, they get up to a 4. So this can get pretty high pretty quick. So this is a very, very common tool that we use to describe how severe our patients are. I think it got so common that everyone was like a 7 and like no one was a 1, and everyone was a 7. But it really is instructive because it tells you like people do suffer and you have to listen to your patients. So I think it's a powerful tool. I image most of my new thyroid eye disease patients, And I am looking to see how much room they have in their eye sockets, because the biggest risk factor for someone to go blind from this disease is a tight eye socket, a tight orbit. And so I'm always looking at this space here, and do the muscles crowd the optic nerve, this space here, and then these are the eye muscles. And this guy has some room here, and that's the optic nerve right there. So you kind of want to think about how much stuff is in a styrofoam cup, right? And if you push a lot of stuff in a styrofoam cup, it's going to be under pressure, right? But if you have some room, the eye tends to do pretty well and the vision tends to stabilize. So this is very, very helpful, and I pretty much get a scan on every new thyroid eye disease patient. Usually a CAT scan. A CAT scan is an X-ray, and it's basically slicing the head or the orbits in several directions. And an MRI is less useful. An MRI is a magnet. It has no radiation. So an MRI is helpful, but these patients tend to pretty much get CAT scans. Unless I'm looking at a muscle and I really want to see what it looks like, an MRI can be useful, but most of my Graves patients just get CT scans. You don't necessarily have to have contrast with that, especially when your patient will be worried about it. CT scans also, like I said, it's radiation, so patients can have some concerns about that, so you really want to counsel them about that as well. Questions? Anybody have any questions so far? Does this make sense? Okay. This is the typical patient that sort of walks into our office, right? These patients have what's called chemosis. Can you see this swelling, the redness on the left eye? They have a little bit on the right eye. The guy looks bad. He doesn't necessarily want to leave his house. He has a decreased quality of life as a result of this. It can be a very disfiguring disease. So patients, again, they can get double vision. They can lose vision. That's what we call functional quality of life impairments. There's psychological impairments, right? People don't necessarily want to have their eyes look different from how they were born. I always look at everyone's driver's license, because then you can tell, is this new or is this old, or is this, because I see a lot of these patients. So their driver's license can oftentimes look very different from how they look when they're sitting in your office. And it's a very emotional disease. The thyroid regulates a lot of our energy processes. The thyroid can regulate sort of some of our emotional processes. And at the same time, the patient's starting to look a little different. So you have to really sit there and empathize with them, because this can be very disfiguring. And that's very important. So I just want to show you guys this curve. This is an old study. It was done in the 1950s, and there were only 4 patients in the study. It's called Rundle's curve. And what Rundle decided was that he basically took what's called a Hertel, or an exophthalmometer, which is what we use to measure the position of the eye in the orbit. And he said, okay, how does this disease process work? What happens with this disease? And how can we counsel patients as to how they're going to do? And what he saw was that there was this dynamic phase that we discussed before, which was okay, this is ramping up and it looks really bad. And then there was a static phase. So the dynamic phase was 18 to 24 months or so, 12 months even, where it got really bad. And this was before we had any medicine or anything like that. This was kind of how we looked at this disease process. And then most patients would get better with no intervention, but they never got back to normal, right? Normal was here. Most patients kind of plateaued. Oh, you have a handheld mic. Okay, cool. Thank you. All right. Hello? Is that better? Okay. So most patients would get back to some form of normalcy, but they never got back to square one. Okay, so this is how we talked about thyroid eye disease. And if you actually go back and read the paper, it was a very, very small number of patients, but it was, the guy was actually a genius. He was an endocrinologist, and this was in 1948 or 50 when he came out with this sort of study. All right, so let's talk about questions so far about the disease process. How young could you be to get it? It's a great question. I have seen an 8-year-old with it. Yeah, and a lot of teenagers. And it can be very, I have one kid that, he was amazing. He was very disfigured from it with very limited options. I mean, some of the therapy, you don't want a kid on steroids forever. We don't think kids should get Tepezza probably right now. We're not. I mean, there's some debate there, and then you have to do decompression on them. So it can be pretty disfiguring in a child. And I have seen many. It's not necessarily most of the patients are not children, but I have seen like an 8-year-old. I've seen a bunch of 13-year-olds. Puberty age kids can get it, and they can be very challenging. But I have one kid who went to Jesuit. He's a great kid, and I decompressed him, and he did well. But he's great. You would never know he had it. He never acts like he had anything. And he's done great. Has a sales career, but it's still, they don't look great. When you look at them, and they don't look like a normal kid. So yeah.
What does early prevention look like for primary care providers to be able to recognize those things?
Yeah, so it's a good question. So one is you want to make sure they don't have a mass behind their eye, like that's another red herring. So you want to make sure they don't have rhabdomyosarcoma or something really bad. And the pediatricians tend to refer anything to us first. And I do a lot of peds, so they send us the patient, and then we're sort of on the hook for working it up. So I don't know if they catch it. They just kind of will call me and say this eye looks really weird, and it's just kind of the way it works. But I think in a bigger system like a children's or something like that, they may go a while without getting diagnosed, unfortunately. And oftentimes their thyroids are normal too, or not that far off, but it can be pretty disfiguring. I've had a couple kids that it was really sad. So it's a great question. Questions about diagnosis. This is a multidisciplinary disease, so you probably need an endocrinologist if you see a patient with this disease. They probably should have one. Internists can do some thyroid stuff, but I think they probably need an endocrinologist. Now, the endocrinologists are getting better about helping with the eye disease, but they're not going to probably manage it like an ophthalmologist would manage it. The other thing is this can go misdiagnosed for a long time. And patients bounce around with double vision for a long time, and they come to my office and you look at them and you're like, you have grays, and this is not that hard, but just because that's what I'm used to looking at. And so some of them get lost in the shuffle, and it's not a black and white diagnosis. There's some levels that it can be confusing sometimes as to what it is. So, okay. Yeah.
Regularly catching this and referring this?
It depends.
Okay.
It depends on who. It depends. We're so subspecialized, everyone is now. So everyone's basically, if you have one weird lab, you're kicked out to a specialist, right? No, I'm just, in all honesty. So endocrine is a very underserved specialty, in my opinion. I don't think we have a lot of endocrinologists. It takes my patients 6 months to get in. So you want one on your team that you can text and be like, hey, I need your help, because you always want to try to get the thyroid under control. That's your goal initially, right? Some of them are starting to actually treat patients with Tepezza and things like that. So it just depends on the doctor and your relationship with them. But and then there's some great internists or GPs that can manage the whole thing and there's no issue. So it just depends. But if they're going to need radioactive iodine, or if there's a question of a nodule or thyroid cancer or things like that, you really got to have them managed by endocrinology. Questions? Any questions? Okay, so let's talk about some how do we treat this disease? What do we do? Okay, you diagnosed it, great, but what do you do next? This can get worse over time. It can cause damage. There's some mild damage. My sister still has really dry eye and texts me every day about her dry eye. And so, I can't really fix that all the way. But again, so that's not permanent damage, but she suffers from this. And so that's a mild chronic problem that she has. But there are some real sight-threatening complications, double vision can be really annoying and bad and can affect the way people work and live and drive. So that's a more threatening complication. You can watch them. I tell everyone not to smoke. This is a big deal. No vaping. That's a real hot thing. Well, can I vape? I think any tobacco product should probably not do it. And they don't all stop. It's just, we don't live in a box again. People are people, and they're going to do what they're going to do. And I think my biggest lesson over the last like 10, 12 years is to just accept people for who they are and don't judge them. And it's not easy to stop smoking. But I would definitely try to get them to stop smoking. And every once in a while it gets through and they stop and they're happy and it's great. Keep them lubricated. And then we know that like selenium at certain doses can help the disease process. And there's been some studies about selenium and steroids, and it has some pretty good utility here. All right, so patients who are active and they're acutely going blind, let's say, and they have severe acute onset, I always put them on steroids immediately. And I would strongly recommend surgery to give them more room in that styrofoam cup, right? So break the walls of the styrofoam cup and get them more room so that they get their vision back. And so that's a pretty acute, like I call that like ICU Graves' disease, because they need surgery right away. And it happens to me once or twice a year that someone comes in and they can only see like your hand or light, and they need urgent surgical intervention and steroids. And a lot of times you can get it to turn around. It'll help with the inflammation. And so steroids do have a role here in addition to surgery. There's been a lot of studies about steroids. It was really hot before Tebro came around. Like 2018, there was the UGOGO study, which showed that IV Solumedrol had a lot of efficacy and could help. And that was given over like 6 weeks. Patients for 12 weeks, 6 weeks of one dose, and then a lower dose for the next 6 weeks. And those patients did really well. So steroids. Do you infuse Solumedrol at all? I mean, we've sent you a few, I think, over there. So it's pretty helpful. It's a really great tool, and it may or may not like last, but it can calm things down for a while. Radiation. How many of you guys have heard about like radiation for this? Yeah, I mean, so that was a super hot topic maybe 20 years ago, where they would radiate the orbit with low dose radiation to calm the process down, just like we would radiate a cancer. They would do radiation on the eyes, and I've actually decompressed a few of these patients. They have a lot of scar tissue, and these are hard patients to manage, so it can help. And I have a lot of patients who've had it, but bells and whistles always go off that I probably don't want to operate on that person, because it's hard once they've had radiation. Just like if they had radiation on their breast or somewhere else for cancer, that creates scar tissue. This is the same sort of deal. And then a great add-on to my career has been Tepezza. And how many of you guys have heard of it? I mean, yeah, okay. So Tepezza was approved in January of 2020. I was somehow alive and open during COVID, and I do a lot of trauma and emergency, so I just kind of stayed open. So I had very early exposure to this drug for whatever reason. I was busy and I was the only one that was around, and so I've had a lot of really good experience with it, and I feel very fortunate to have been around at the beginning, and so that was awesome. The COVID vaccine took over one of the factories that was producing the drug, and so we had this huge shortage for a while, but it was a really interesting process of uniting industry with new technology, and several phone calls with the guy that figured out the drug. It was a really exciting time for us. These patients did great. Their disease sometimes just like went away, or they looked 1,000 times better than what they looked like when we first started with them. What is Tepezza? It's a monoclonal antibody that targets the insulin-like growth factor 1 receptor, and it's given as 8 infusions. It's one every 3 weeks. It's a half dose the first time, then a full dose, and then that's over 90 minutes, and then the full dose for the next 6 infusions over 60 minutes. And basically 80 to 90% of these patients had a significant improvement compared to placebo with their proptosis, their bulging, and their double vision got better, and they felt better. That CAS score that we talk about got better. We don't give it to pregnant patients. There are some side effects. It's not, again, we don't treat people in a box. Glucose can go up in their body. We know that hearing can be an issue, muscle cramps, and we don't give it to anyone who has inflammatory bowel disease. In fact, I had someone today who really needs it, and she has inflammatory bowel disease, and I just stay away from it. There's been some worse reports that can get really bad with this drug. So, and this is sort of the typical patient. This looks like one of the first patients I treated. I don't think it could be, but the on the right side, there's all this injection. The lower lids are down. It looks like almost like the lashes are rubbing on the eye, and the patient's eyes were bulged. And then after they took Tepezza, I mean, they're basically back to their normal self. So that's pretty powerful, right? Yeah. Question.
When you do give that, is it given in your office or an infusion center? How is that given?
So we typically refer it to an infusion center, and we have great help with that. And it's gotten better as we've get more experience at this. It was hard in the beginning because it's very expensive. So as the drug becomes more like available and everyone's sort of using it more, the infusion process has gotten way simpler. But it was difficult in the beginning. I had like an employee just dedicated to this drug, and that's gotten way better. So, so then we talk about surgeries, right? So again, not everyone is the same. So we talk about orbital decompressions. These are the patients that are going blind. We break the styrofoam cup to give the patient more room. There's basically, think about there's the inside of the cup, the outside of the cup, the top and the bottom. And oftentimes we'll break the inside of the cup and the outside of the cup, the orbit, the medial orbit, and the lateral orbit to give more room so that the eye can have room to breathe. And that's called a decompression. The medial decompression, this area we do sometimes with ENT because they can get up there and get the bone out, and it's really safe. And then this part we'll do ourselves through a little incision in the eyelid, and we'll cut some of this bone out right here. It sounds terrible, but it's really not. And then we'll get fat out so that the eye can sink back a little bit. It'll give you 4 to 6 millimeters. Some people say they get more. I think 6 millimeters is a pretty good number, 4 to 6 millimeters. And the drug can do that too. I mean, I kind of like stopped doing decompressions for a while because the drug did that itself. So, strabismus surgery, this is a lot of what we do, correcting double vision for patients that are impaired by this disease. And that's done with a suture. We take the eye muscle. There are one muscle that moves the eye up, one that moves the eye down, one that moves the eye in, and one that moves the eye out. And then there's 2 oblique muscles. This disease tends to affect what we call the rectus muscles. The most common muscle is the bottom muscle called the inferior rectus muscle, followed by the medial rectus muscle. And it can affect other muscles too. I've operated on all the muscles for this problem. And we will relax the muscle so that the eye is pointed down. We relax the muscle and the eye will come up, and a lot of times it fixes the double vision. But that's something we need to have in our back pocket if we need it. And the decompressions can sometimes give the make the eye muscle disease worse. Those patients are done under anesthesia. They're asleep. And then we do a lot of eyelid surgery, and these can be anywhere from like shutting the eyelid to dropping the eyelid to taking skin off the eyelid. And there's a lot of variations to this. And nothing's perfect, but we can do a really good job of disguising this disease. So tell your patients, if you think they have this, see someone who knows about this disease. And again, we have a multidisciplinary team. So I think psychological support is something that like we need to just do better at. Like I think as I've matured a little bit, I think I have a lot more patience to listen to this because it's important. It's not that it's I might have like listened halfway 5 years ago, but I think now it's really important because people want to be heard and they're there for your input, and so I think listening to patients. And I think emotional support, groups like this, is also really important. We need to lean on each other. Stress is a big thing, so keep the stress low. Keep the eye lubricated, and tell people not to smoke. So what can I answer? That's a lot of information. Questions later or not, whenever? You want to do them? Do I have a minute to do them now? Okay, yeah. Yes.
This is highly specific, so bear with me if you don't have a good answer. So I work in high-risk obstetrics and recently have had a couple of autoimmune patients and one who did have TED. Is there anything you can do? Because obviously you can't give the drug. I've never met a surgeon that's not an OB that likes pregnant people.
Yeah. So are you an OB? Are you an OB?
No.
Okay.
I'm a clinical nurse.
Okay.
And we don't want to dose them up crazy with solumentrol. Is there anything to do to delay progression?
I try to like not even dilate a pregnant patient. I mean, I my level. I mean, I'm a relatively like new parent. I like the last thing you want to do is intervene. So we have several patients that have had crises or you really just try to watch their vision through the pregnancy and make sure that they're not having a vision threatening problem. And it tends to get worse during pregnancy. So if they get worse, and they have double vision or something, then you would fix that later. Maybe not, unless they were really losing vision. I'd probably decompress them I'd probably do like surgery. It'd be the safest, probably, rather than a drug. We can put someone to sleep pretty safely during pregnancy, and you can get a decompression done probably in 20 or 30 minutes. And so if they were really losing vision, I don't think I've been in that situation. Now, where I have been is like, I've found skin cancers on patients that are 35 weeks pregnant. So like similar situation. I wait every time. Like, I mean, that thing is resectable in a month, just like it, so I try to wait if they're pregnant. I think it's very sensitive, but even like a sty,
Active phase of like 6 months
yeah,
to 2 years.
yeah, but even like a sty on a pregnant patient is no, I mean, it's a big deal. I mean, I think you really have to think through anything you're going to do to someone who's, like even epinephrine and local could trigger, things. So I'm very conservative with them. I would try to wait till they're done, and then you could either do this or, decompress. But if they were really in trouble, I think surgery would probably be your best bet. Yeah, it's a great question. No, it's great. It comes up, so it's important. So. I appreciate you guys having me. You have a question? Yeah.
Real quick, so from, thinking about the vision screeners that go in there, these symptoms are things that they should be looking for when they're screening patients, doing visual screenings
Yeah, are you screening adults or kids or both? Or? I mean, if you see, I would bet that at your screenings there are people that walk through there that have active eyelid retraction and graves and bulging of their eyes and probably need to be worked up. Yeah, I mean, I think you got to look at the patient first. So you teach your screeners like this is what Graves' disease looks like, just like this is what esotropia or exotropia. I mean, you guys are great at like picking things up. I think this should be on your teaching picture. Like this patient should be referred to ophthalmology for. Yeah. I mean, I would just put it in there. Yeah. Just like you see a kid with leukocoria, like a white pupil or something, this should be the same bells go off that they should be. Yeah. But I think there's a lot of good pictures that you can find and we can provide that, that would be great to pick up a lot of people. Yeah. Yeah.
It's a chronic disease, and if the patient does like surgery to reduce the inflammation of that, how often does it come back? Does the inflammation come back?
Post-surgical. So you can get what's called a flare, where like you're doing great, and then 20 years later your eyes go nuts for a little bit. So that's the most common post-surgical problem, and that can happen anytime. People can flare after surgery immediately. People can flare years later. I think with Tepezza, it's hit or miss. Like some people do great for like a really long time. You never see them again. You never have to treat them again. There are, I think, 20 to 30% of people, I've treated people twice and they've done well. The second treatment tends to work a little better. But they tend to do great for like a year and then they kind of get a little flare and then you got to get them back on the drug, But it's individualized. But I think post-surgical flares are similar kind of data. So, I mean, I've had muscle patients that you get them really good and they're straight and they have no more double vision and you see them like 2 years later and it's like a totally different strabismus than what they had. I have a couple of people like this. And that's someone I would probably treat with the drug first and then fix their muscles after. So. Good. You have a question? Any questions? Anybody else? Okay. Great questions. Good. Okay, well, you guys can get my information. I'm always available if you need anything, and really am honored to be here, so I appreciate it. So.
Well, I can speak on talk about that in a hot minute. So you can hear my story a little bit. But so I'm a patient advocate. I'm also a healthcare professional. My name is Layla Lohman. I have 2 kids and a husband. Been together for 21 years. Kids almost 10, and the youngest is almost 6. I have a healthcare management company first, I'm clinical director of. I also work in private practice, working 3 days a week as a dentist. I call me the primary care provider of the oral cavity because I am a collaborative clinician, and dentists fix things, and I have an oral systemic connection, is the mouth is the gateway to the body. And then I also became a patient advocate 4 years ago, during the time when I was in the middle of Tepezza and I was in the middle of treatment where the biologics got stopped due to COVID. And I understand all the science behind it because I'm 6 inches from people's mouths. I worked I think March 31st it got closed, and I was back to work April 14th because you didn't want to send patients to the emergency room. So I got a little frustrated in the middle of my treatment, living with thyroid eye disease, and then the vaccine stopped the manufacturing. So that's when I became a patient advocate. I actually was diagnosed in 1998. I was 12 years old when I was diagnosed with Graves' disease with exophthalmos. They actually didn't call it TED at the time because Graves' disease also has, like Dr. Shulkin said, like the ability to push your eyes out with Graves'. I'm Iranian, so people just thought I had big, beautiful brown eyes because I'm Middle Eastern. And then I lost weight rapidly, and my mom and I are close, and she had to ask really hard questions like, are you anorexic? But she said that nicer at 12. And got checked, and I was on 12 medications a day 12 pills a day to suppress the amount of my thyroids were producing. And I'm obviously a healthcare professional today, but I believe that it takes a village to communicate better, and I think our patients and our healthcare providers. I think Dr. Shulkin, I've been with him since 2015, and I actually work with 2 ophthalmologists for my care, and I'm very open with both of them that I work with 2 providers for my treatment because they come at it from 2 different views, and it allows me to tailor my approach based on their expertise and then guide that treatment. Now, I also have the position that I'm a healthcare provider, so I may do the good and the bad with it, so we'll see. But in 2000, I had to have a thyroidectomy. So what you can't really see in that photo is I had like a scar from like here to here I was 12 diagnosed, and I was at 14. And most of the time I would try to minimize the condition, and people would ask me in like the middle of the grocery store, like, did you try to kill yourself? Like, because it was like a really red scar, and I was 12, and people are rude sometimes. I'm a twin, so I always had a best friend to protect me. But what you can tell here from this photo was I was never diagnosed with thyroid eye disease. When I had the thyroidectomy, all my doctors back then said you were fine. And then I just had severe dry eyes, and it was allergies. And so it was just a reason after reason because they weren't really aware of TED. At that time in the industry. And so I was always over complicating photos because I naturally was trying to stop double vision, even though I didn't know it back then. And so like I would cut out all the photos because when I would do certain things, my eyes would retract, and I would be so embarrassed that I looked that way. Now, if somebody else looked at that, they would be like, she looks like a normal individual with really pretty eyes. Not to somebody who lives with a disease where people tell you like, oh my gosh, did you know your eyes are humongous? And like I got called bug eyes at 12 and like bullied. And so like it's a silent condition that like you just try to figure out how to live through it. So that's why I was asking how young you see it nowadays. And that was during pregnancy. So in 2015, I got pregnant at 30, and I started getting pain within like 4 weeks of being pregnant. And I've always known, like they told me thyroid conditions can cause miscarriages, so you have to be like really early on because your body's changing and the baby, all the things that they tell you, but you don't really know what it feels like until you live it. And then I started getting double vision, and that's when I went and saw Dr. Shulkin, probably 8 weeks in, and him and Dr. Ahmad, who saw me, they're like, oh, you've got acute thyroid eye disease. And I laughed at both of them because it's like, oh, I had a thyroidectomy. No, I don't. you're wrong. Next. Uh, and this was him in 2015 where he's like, very like, you've got TED. And I'm like, what do we do? And he was like, I think back then they still talked about steroids. Like, it was really active. It was affecting my day to day. So they were talking about like high dose steroids. And I actually had gone to 3 other people before I saw Shulkin because all of them wanted to give me like 80 milligrams of steroids. And I was like, I'm sorry, I'm creating life. Like, what is that going to do to the baby? And they were like, well, like, you have to figure that out. And I'm like, well, it's my first child. Like, guide me. So I went to like multiple people because I didn't get the answer I wanted. Whether it's a good thing or a bad thing, I don't know. But yeah, we did. Yeah, you did. But you gave me the answer I wanted, so. But speaking about pregnancy, none of my doctors wanted to take ownership of the condition. And the eye doctor was like, you're good, like, wait till the baby's viable. And the obstetrician was like, you're good, what does your eye doctor say? And then my primary care was like, I don't know what to do. And so, like, my first pregnancy was the toughest because I still tilt my chin because I'm actually in an acute phase 9 years in, so that 6 to 2 months, the 2 years is not accurate in my box, okay? So all of them, like, I had to wear a patch for a while. Like, my kid came at 35 weeks, and it was my fighting to tell both of them, like, I can't live with this. Like, is the baby healthy? Like, what do we need to do? Like, I'm going downhill quickly. And so I had to tell, like, neither one of them wanted to take ownership of taking the baby early. So the first one, I was like, I don't know what to do. And then they usually just tell you to be on bed rest. Well, that sounds awful because I still have, like, severe pain. So, like, it's a balance between the risk and benefit of having that baby early and am I going blind? And it was, like, I was never not going blind. So, like, they were never going to risk surgery for me because it wasn't a beneficial thing. So that was pregnancy. Family planning. I asked how common was it to get it a second time around? And I think I went to Dr. Ahmad at that point, and Dr. Ahmad was like, it was so rare to get an acute phase the first time. Like, I can't tell you never, but, like, it's very rare. I had multiple miscarriages during that time, so 5 pregnancies, 2 live births. I knew I was pregnant because double vision happened, literally 4 weeks in. I was like, we had just planned to not have any more children, like, we were done. And I was like, we're walking, and I'm like, oh my God, I think I'm getting double vision again. And then I peed on a stick, and I was pregnant again. And this happened again. And my second child came at 36 weeks. So it's a little bit where you have to have collaborative care. And the obstetrician is never going to say, let's have a C-section because of the baby. Like, no one wants to take that liability. And that's why I think advocacy is super important, where you have to decide what you can and can't do. And you have to find interdisciplinary care that's willing to go to the gray with you and find a way to get there. Because as soon as I had both my children, it was like 70% relief. Like, all the inflammation came away, and I was like, oh yeah, I can survive. Like, I didn't think I could survive like 40 weeks with that. So now I talk about patient advocacy because one of the things I've learned over the years is imposter syndrome is real. Honestly, like, growing up a girl, sorry boys, growing up a girl in a world where people just tell you, like, bake and cook, and yes, you can be anything you want to be, but also can you take care of the kids and make the doctor's appointments and do everything that you do on a Rolodex plus do well? You're like, yes, I can. And then, like, you look at yourself in this game of life and you're like, I'm a queen. And then, like, you act like a pawn sometimes. Or sometimes you are a queen, or a pawn, but you act like a queen. And so what I've seen over the last few years through advocacy was, if you don't know that level of self-awareness, like, let's start there. Because no matter what you do in your advocacy, whether it's your own personal advocacy, medical advocacy, if you don't know where you're at, you're going to be disappointed in what everyone else says to you because they won't say what you want them to say. So how did I do that? 2 tools that I'm going to share with you today. The Arbinger Institute is a company that I went to a 16-hour course 2 years ago, and it put into words that I used to be the queen of excuses. And then I would get frustrated that, like, when I thought someone and I would blame somebody for something, I just justified my choices away. And so what it really brought to light was in box and out of box. I liked Dr. Shulkin's box reference because when you're overthinking, and I'm a recovering overthinker, when you think your choice is taken away, it ultimately is because you betrayed and you didn't know what, like, you didn't honor what you wanted to do. And it's either you let somebody influence you, but that was still a choice. And so it's typically one of these 4 boxes that you learn yourself. So some of the self-views in my healthcare world was fear of being judged by other providers of the care that I delivered, and fear of being watched at times. And so I would get stressed and overwhelmed in the healthcare profession. In the better than and worse than, sometimes I felt powerless with kids. Like, they take everything from you. They need you for so many times of the years. And then finally at 3 years old, you're like, you're a human. I can, like, walk away without you dying. And so you feel like you compare yourself, and that means you're in your inbox. So, like, anytime I had a disagreement with my disease state or my personal life, it's probably because I saw these self-views and then I felt these certain things and I was just like, fuck it. Oh, sorry. Screw it. Like, I'm resigned. This is my life. Like, I guess I just have to get through it. But as I started seeing when I'm in my inbox and what triggered me, it made me a more effective human. It made me a more effective healthcare professional, and it made me a more effective patient. So it helped me realize that, like, I don't have to resent my provider for not giving me the answer I want. I need to ask better questions. So the other tool that helped me was understanding my communication style. I used to laugh at people, and you can decide which one I am at the end of this, but basically I started realizing that I used to think that if you didn't smile at me, you didn't hear me. So I wasted a lot of time, energy, and effort to get you to, like, connect with me. And now I'm like, no, either they hear me or they don't. Whether they're in their own heads, it's on them. I need to make sure that I'm present. So what this helped me allow me to do as a professional in my personal life, professional life, is if I know what my style is, I can bring down, everybody has every one of these in them, to be honest. Like, you have every single one of these styles in you. Some come out naturally, some come out at work. And if you are exhausted at work, it's because you're bringing in you're trying to bring in something that's not natural to you, so you feel tired. So once you start learning what you are, you can actually leverage and pull out the other ones each time, depending on who you talk to. So I'm gonna talk about it from the patient side. So if you have a patient that is very analytical, and you're going to tell them about a treatment like Tepezza, they're going to want to know the science, the risks, tasks. They want you to be quick. They want you to be quick in telling them, but they're going to be slow to answer. And so you will not get them to say yes to any type of treatment till they have time to process it. So as a provider, you need to understand that. But if you're a C in a patient and you have a D as a provider, that person will never be slow. They're going to be direct. They're going to be like, this is what you need. Let's go. Let's make quick decisions. They're going to be results oriented. And then you're going to sometimes clash. The most common ones that clash are task oriented versus people. I will tell you, I'm an I. My husband is a D, and I just learned that 2 years ago. And when I learned how to communicate with him, especially with compassion fatigue is real. Like, I have lived with chronic health issues since I was 12 years old. I'm 40. It's a long time. I've been with him 21 years. So when I realized who he was, when I talk about things, I love people, he loves tasks. So I'm already gonna combat things. So when I talk about my health with him, I'm like, here's what the treatment is. So let's say Tepezza. Here's what the risks are. It's supposed to make me feel better, and I want to go to our kids' soccer games without hating it. Like the light, the bulging, the sensitivity. Like, I hate the outdoors. And he saw me as lazy, didn't want to go things, he's the kindest human in the world, by the way. Let me just tell you, like, half of this story that I'm telling you is my version, so. So, but he, he's like, don't you want to go to his game? And I'm like, no. The answer is no, I don't want to go to my son's soccer game. No, the answer is yes, but, like, everything about outdoors caused my condition to get worse. So here is where our patients need to understand, if you don't know your communication style, and then you expect your provider to know it, you're going to get miscommunication because they're never going to reach your level of expectations if you don't know how to communicate it. And if I'm a high I and I'm going to a C, I'm going to think he doesn't care about me because he's not talking about my family. He's not caring about me as a human. He's task-oriented and he's slow. I'm fast-paced and people-oriented. I'm leaving that provider all day, every day because I think they don't get me. What if he's the best guy in the world? So if now that I see this, I can ask more questions, and that's where the little patient conversation comes. So as a patient advocate, I think the patient's role is to understand that if you have self-limiting thoughts and someone's trying to help you, you're going to ultimately be disappointed. If you have empowering thoughts, you might become a confident patient, but you also have to leverage the healthcare provider's expertise. Like Dr. Shulkin said, this medication wasn't available before 2020. We did what we knew when we knew it. Now we know better. So basically, we all try to change results, and we're like, oh my gosh, why aren't you guys doing your job? Why isn't the healthcare? Why is your front desk? Which now I call them administrative professionals because they're not a piece of furniture. And so what we try to say is it's the mindset. And living with this disease for over 27 years, I get demoralized at times, but I can't let that drive me, or you do get into a bad mental health state. And again, I've been going to therapy for years. This is a word that people just throw all the time, like, trust me, trust this, trust this. But what people don't understand, that there's so many factors that develop in trust, that they have to have competence, which you go to your healthcare provider. Your healthcare provider has to be consistent, but so do you as the patient. How many times has my doctor said, use eye drops, Layla? I'm like, sure. And they're like, do it 20 times a day. Really, like 7. I do it twice. So if my dry eyes never get well, it's because I'm not consistent in doing what's recommended, because it doesn't work in my life. That doesn't mean I don't trust them, but if I don't tell the healthcare provider and then they're trying to change my treatment, I'm not consistent. So the trust goes both ways. So it takes a lot more to build trust with chronic health conditions, and that's why patients have to realize, like, stop lying. I know you didn't floss yesterday, or you flossed yesterday, but you're telling me you didn't do it for 6 months. Like, I'm very clear with my patients, like, I need to know what you're really doing to help you get the better health, but I can't do that if you don't trust me, and trust believes is where you give me the truth. So I think you have to speak up to be seen. That doesn't mean you have to be the loud voice, but you have to talk. If you don't talk, you're going to have unsaid, unmet expectations and be disappointed every single time. So what I find that builds most confidence is through advocacy, is learning communication styles. And, you know, I already knew Dr. Shulkins. He didn't even have to take this. But you kind of know where people are at, so then you can tailor your conversations. And I think our healthcare providers need to learn that too. Our healthcare providers think that they're done this for 15 years, 45 years. I'm great at what I do. I'm not saying you're not. But are you communicating the way your patients need to hear you in order to accept the care you prescribe? And if the answer is yes, great. If you don't know your case acceptance rate, then you don't actually have an answer for me. So it's a really humbling experience as a provider to look at your case acceptance rate. What are 3 things that you could help me understand about my condition? It's new to everybody who has it. It's not new to him. He sees it all day, every day. He could probably look in this room and be like, you're probably at risk. Like, you're probably at risk. Layla's left eye is bigger right now, so she's having an acute phase. But he lives this. So for those of us who are new to the disease, ask, what are the 3 things I need to understand about this disease? And then the professional will tell you, like, this, this, and this. What are my treatment options available? And if they're just like steroids, that's what these programs are for. That is a traditional way to do it. There is a use for it. It needs to be in your toolkit. That is not what the new technologies available today allow, and they need to be able to know, if you don't know it, then send me to a colleague who does. It's unfair for me to live with that much debilitation, and then you just say, come back and do a high dose of steroids. That has a lot of that has a lot of systemic risks too. And then like what Dr. Shulkin said, support. I think the strongest individual is somebody who's vulnerable, because it takes a strong person to be able to share that story and connect and being like, yeah, it sucks, but I'm not going to let it define me. I'm not going to let it victimize me because I want to show resilience. So finding where the support you can get is by the advocacy groups here that are sharing, like, there's people who live with your condition all day, every day. Here's her cell phone number, and you're going to get it at the end of the day. So here's where the most common miscommunication is. I don't feel heard. Well, did you say what you needed? And most of the time it's no, because they're constantly overthinking where they don't want to waste the doctor's time. They're already running late. They're already this. Like, that's you in your own head. The provider can't help that. They're on a 15-minute schedule. Like, they're trying to be present, but with the healthcare system the way it is and insurance this way it is, like, it's a volume-based game, unfortunately, and we have to just accept that. That doesn't mean you have to, what I've told people is, like, if you're, like I said, what would you do if this was a family member? But in general, if your provider's like, oh, if you feel your provider's rushed, you can say, Dr. Shulkin, can we reschedule a time when you maybe have 30 minutes for me to talk? And he's going to realize that maybe he was having 17 patients that he was running late on. And then he'll be like, okay, Layla, here's 5 more minutes. Like, he won't say that, but he'll give me the time. And then you can do it. But what if he had an emergency acute patient and I wasn't acute and they needed surgery? I probably don't think about that person because I'm in pain. But patients need to understand there's difference between emergency and that you need management. And so, like, as a healthcare provider, we have to balance that risk. And so the patient needs to understand, like, I want to give you the time you need. And usually what I'll tell them is, like, could you go back, email me your questions, and I'll get back with you by the end of the week. And if you don't hear back from somebody by Wednesday, call us on Thursday, and I'll make sure to spend time to call you on the phone. So there has to be that bridge that doesn't get misheard. So second opinions. People come to me all the time for second opinions. I ask them if they want a third because that's the trust. And I never get offended if you want a second opinion, because even if I would have treated you, you probably would have been upset with me with the treatment because you didn't trust me. So I believe second opinions are very fair. Now, whether or not you're going for the right reasons, you as a patient need to see that. So I believe this is the expectations. I think that messed up. So powerful providers are supposed to be on the other side. But I think these are the expectations people need to understand. Like, you're the patient, you live with the condition, your provider is your partner with providing that care. You need to understand your emotions before you expect them to manage it, because it's personal and you live with that condition. But they are also emotional, but they have to separate themselves because they see this all day, every day. So you may think they're not empathetic, but they're also trying to manage that they don't give you all their energy so they don't go home like crying to their patients or crying to their family. Not that you would cry, but I probably would. And then just research and options. I don't love Dr. Google because I feel like there's not great information. They always talk about like a lot of the bad, but you should still do your research so that you can come prepared. And then I think the provider's expectation is to educate on the available options for thyroid eye disease in my case. And the most important one is the decision maker. You decide. You weigh the risks and benefits. Whether you believe you're going to be one in that million that gets that hearing changes, that's not the manufacturer's fault. That they told you the risk. That's not your provider's fault. They told you it was a risk. You just have an invincibility cloak that you just think it's not going to happen to you. So you have to own your decision and understand, like, what can I do next? But it is the provider's job to guide my decision because they're the expert in their field. And it was really challenging for me during pregnancy when nobody would guide me. And then I'm like, is my baby going to live if you take him? Like, what do I need to do? So, like, it's a very challenging world to live in. But it all boils down to unsaid, unmet expectations. If you never say it, no one can ever meet it. And then it's a constant cycle of disappointment. So this is how I went from powerless to powerful. I was diagnosed at 12 years old, had a thyroidectomy. I managed my condition based on dry eyes because no one told me I had TED. And then during pregnancy was diagnosed with TED. And then from 2020, I've done the therapeutic medication twice. I still have an acute phase. It comes and goes, but again, the therapy never said it was a cure. It said it was to manage my condition. And I wish I was one of the ones that took the medication and it never came back. I pray for it every day, but it doesn't happen. So what do I do now is I just make sure I have a community and conversations, and I don't shy away from them. I look at new therapies, new treatments. Can I take another round of Tepezza? What am I going to weigh the risks and benefits for me and my family? Because it does take a toll on your body. It's an infusion. I am a healthcare provider, so I have to manage it between my patients and managing my conditions, but a lot of people have health conditions. So diet, stress, I mean, seriously, just waking up is stressful. Like, you have to go to work. Your kid's like, I'm hungry. Your husband's like, is it your turn? Like, I mean, that is literally, you can't stop that. So I think the best part was understanding, like, what are choices and my communication, which has allowed me to reduce my stress. So I no longer worry. So here's where the power shift comes. You change your circumstances to choices. They're not circumstances. You're today. I'm here today. This is a choice. I've made a decision to speak to you today. I'm not worrying about my kids. I'm not worrying about bedtime. I'm not worrying that my husband's killing my kids. Like, he's not. But the thing is I used to worry about all those circumstances that didn't allow me to be present, which then took away time. So worrying costs you the one thing you can't get back, which is time. So that's one of those things where my choices became my choices, and I know what my priorities are. I plan and prepare, and then I try to figure out which one today am I going to work with. Is it my overall health? I'll eat healthy today. Is it my pain and discomfort with my eyes? Am I going to treat my condition? So, like, you have to decide that. No one else can. And if you give that to other people, you're going to be frustrated every time. So, 2 more slides. I stopped letting fear decide my fate. The 7 most common fears are typically one of these 3 things: fear of the medication failing, and then I have to still live with this disease. Still happening. I still have to deal with it when it happens. So stop worrying about it. Stop fearing it. Fear accountability. Got frustrated with healthcare professionals not getting me in on time, 6-month waiting periods. I stopped at one of their doors one time during my pregnancy, and I'm just going to sit here. If no patient shows up, I will be here. Let me just sign everything away. I sat there for 4 hours, and it is what it is. You have to live and manage your conditions the way you can. But again, it's typically one of these fears that drive you. And so once you learn the tools to stop allowing those fears to make those decisions, you become the person you're meant to be. And managed patience starts with crucial conversations. So barriers will become bridges when you learn how to communicate well, and communication starts with self-communication in your own brain. And in general, you have to know awareness, you have to understand, and you have to get curious instead of defensive and offended. So when you come from a level of curiosity, it helps reduce the burden of pressure that you're making a mistake, because you're always coming from a place of curiosity. People get annoyed that you ask 5 more questions, but I don't create a story about what I think you're about to say to me. And then self-management of your condition and provider management. It has to be a marriage, but you're the one who lives with the condition, so you get to decide where you want to go. If he did orbital decompression and I chose that and it didn't go well, most people blame the provider. I mean, it's just natural because you don't want to take any accountability for yourself. But that's what the risk conversation, that's what informed consent is. So educated patients are smart patients. Smart patients make informed choices. And if you miss the first 2, there is no informed choice. They ultimately shouldn't have done that treatment if they didn't understand the risk involved. If, a lazy eye or the lid retraction didn't go well and it over-corrected or something like that. Like, that's a risk. So know and do your part to give you that control that you want back, but you can't control anything about being present today. So thank you from the patient side for thyroid eye disease. Yeah. Oh, yeah. So I was the dentist for the last man in iron lung for like 4 years. Yeah. Yeah. I put that in because it's like a fun fact that I never told anyone until he passed away. What? Paul Alexander. Yeah. Doing dentistry and that is very challenging.
He was a practicing lawyer.
Yeah. He's a really cool guy. Yeah. And then I also say that man smiled more than anybody I know, and he lived in an iron lung. So, like, it's perspective. All right. So, any questions for me? I'll leave that up. I think I answered all of them anyways. I'm just kidding. Yes.
So someone who is just starting this journey, like, what is your advice as they kind of just start this out? Like, what would be like the first thing you want them to do?
Oh, that's a loaded question. For someone who just found out they have thyroid eye disease, first I would just give them emotional support because it's very shocking. So I would tell them to go to tedcommunity.org, like just talk to people who live with it, because you know how many times my best friends who I love were like, just wear sunglasses, just take Tylenol. And again, they're coming from a place of like love. It doesn't feel like love when you feel like you have sand in your eyes all the time. And they're like, oh, did you try this lubricating eye drop? I'm like, I've got the highest prescription strength eye drop you can get. So again, it's not tallying. So I would say the support would be number one, because like those who've lived with it for 27 years, those who've lived with it for 10 years, those who are just diagnosed, like I know what it feels like to feel demoralized living with their condition, so I can connect with them. So emotional support would be number one. So the advocacy groups and stuff. And then find a provider that connects with you. And that's why I think those questions that I put, I'm like, if you have those 3 questions and you ask them, like, what would you do with a family member? And he like, this is what I would do. And they're just like so connecting. It then helps them communicate the way you need versus how they normally connect with other patients. So that's kind of where I feel like the power is lied. Is like, what 3 questions should I ask you? Because in your head, you're creating 17. Great question. Anything else? Thanks, guys. If you need anything, I'm going to stay for like 10 more minutes.
Before we wrap up here, I do just want to do a massive thank you to Dr. Shulkin, to Layla, for being here this evening, for sharing your expertise, for sharing your stories. I want to say a thank you to Prevent Blindness Texas as well. We really appreciate everyone coming out this evening and joining us today. If you have questions, if you have follow-up, please do let us know. We are always more than happy. In everybody's folders, you should have some resources there as well, both from Prevent Blindness Texas and from the Vision Health Advocacy Coalition. You can also find more resources on Prevent Blindness Texas's website, on our website as well, which is up here. But I just want to say thank you all so much for joining us this evening, and I hope everybody has a wonderful rest of their week.